my dear professors and colleagues. Today I will be gladly talking about the fetal echo in a simplified manner to make it as easy as much as possible. We know that malformations of the heart and arterial trunks are the most common congenital anomaly found in humans, and we know that it cascades in families. If we have a previous child that was born with congenital heart disease, the coming one will be at risk of 1 to 20 to 1 to 100. If two previous children, it will be 1 to 10 to 1 to 20. If the mother has congenital heart disease, it will be 1 to 5 to 1 to 20, and if the father, it will be 1 to 30. Definitely we have indications, maternal indications, positive consanguinity, autoimmune antibodies, familial inherited disorders, IVF, teratogen exposure, and metabolic diseases. While for the fetus, increased nuchal translucency, third degree relative with congenital heart disease, abnormal cardiac screening examination, fetal chromosomal anomaly, extracardiac anomaly, hydrops, and monochorionic twins. While the ideal time for fetal echo is between 18 to 22 weeks, below that at 11 to 14, it will be problematic. So that's why we might use transvaginal route to make the heart close as possible to the probe and magnify the heart as much as possible. And beyond that, at 30 weeks, it will be again problematic as the mass index of the baby will be increased in relation to the amniotic fluid, and even the ribs might cascade shadows over the fetal heart, compromising the accurate viewing of the heart. That's an example for the proper positioning of the or viewing of the heart. As you can see here, the first one, the vertebrae is cascading shadows over the heart because the back here is facing the probe or the transducer, so it's cascading shadows over the heart. So we need to bring a better view. Sorry. Like the one on the right side, you can see here that we throw the shadow of the vertebrae away from the heart and we can see the heart clearly. So the best or the ideal view is that the apex should be imposing in front of the probe. The heartbeats, normal heartbeats is between 110 to 1 to 60. And you can see here that that's the initial evaluation of the heart. If we don't see heartbeats, that meaning that the no purpose on further evaluation of the heart, we have intrauterine fetal death. We can check it for further anomalies in the heart, but I mean that's the initial evaluation of the heart to see that we have a bumping heart. Systematic approach, orientation and identification of the four chambers, check the situs, evaluate the size of the chambers, evaluate the heart size, check for mediastinal shift, check for the axis, right ventricular outflow tract and left ventricular outflow tract, assess the 5 chambers view and the 3 vessels view. That's a scheme. You can see it here that we always start codocranial, meaning that we check at the abdomen, we see the gastric bubble, then we go cranially further, check the position and the axis of the heart, assessing that the apex is directed towards the stomach, then evaluate the 4 chambers view, escalating cranially to the 3 vessels view, the trachea and 3 vessels. So that's the route that we follow. I'm placing this image, it's from the literature, it's a little bit biasing. We need to be oriented with the position of the baby. Is it back facing, front facing, cephalic breech, to locate the right side from the left side. So the easiest route is to rely on the anatomy that we have, is that we have here the aorta, the vertebrae, in front of it the aorta. So immediately in front of the aorta we'll have the left ventricle, in front we'll have the left atrium, in front we'll have the left ventricle, the other side the right ventricle and the right atrium. And if we have it in the viewing, if you can see here clearly, I need to play the pointer. Yes, you can see here that's the vertebrae, aorta in front of it, and the heart, left atrium in front of the aorta, left ventricle, and right atrium. That's a scheme of a monoventricle, monoatrium. We check for the axis, we bring the heart, we see the 4 chambers view. Then simply we see we bring a longitudinal line from the spine to the front, to the sternum, and we must assure that the axis is located on the left side towards the gastric bubble that you can see in the upper left side. If you look here at the live images, you will see that the upper one, we have a normal axis, the heart is directed toward the stomach, while if the bottom one, you can see here that the stomach is on the left side and the axis or the apex of the heart is towards the right side. So here we have a dextro condition. That's even in twins. If you can see here, twin number 1, you can see the gastric bubble, the gastric bubble, the hypoechoic circle here. It's on left side and the apex is on the other side, and unfortunately she aborted the twins for this because she had multiple other anomalies. So again, that's inspection of the axis from the vertebrae into the front to the sternum, and the axis should be rotated to the left side by maximum 45 degrees. That's another example. We can see here that we have mesocardia. If you look at the image on the right side, you can see that the apex is directed immediately in the midline behind the sternum. So that's a mesocardia condition. And definitely, as we've mentioned in seconds, the axis, we can assess dextrocardia at ease. Again, checking for the chamber size and the heart size, we bring the 4 chambers view. Then we take both ventricles horizontally. We assess the right side and left side. They should be symmetrical. Then we assess afterwards the cardiothoracic ratio, the transverse diameter between the atrioventricular region in relation to the maximum chest diameter. And here we can easily evaluate the cardiac dimensions. As regards the atria, the right atrium, if you check the upper image on the upper screen, you will see that the right atrium could be a little bit larger than the left one. And we can see that the atrial septum can be slightly deviated to the left side due to slight enlargement of the right atrium, and that's normal and completely normal. The heart displacement, if you can see here, I've just mentioned that the aorta immediately in front of it would be the left atrium. But here you can see that the vertebrae at the back, the aorta beside the vertebrae, but the left atrium is pushed to the front. That means that we have a mediastinal mass that could be missed easily. So if we check the heart, definitely we can see the mediastinum. 5 chambers view, it's this routine 4 chambers view, but the origin of the ascending aorta from the heart, you can see here that it forms a 5th chamber appearance. Outflow tracts, we check the heart, as I've mentioned, the 4 chambers view. Then we rotate the probe to the left side of the baby, to the left arm of the baby, with slight inclination to assess the outflow tracts. That's the appearance of the LVOT, as we've mentioned, from the 4 chambers view. You can see the aorta in front of the vertebrae, left atrium, and definitely the left ventricle, the one that's looking like a foot. And actually, in literature, it looks like a ballerina foot, if you see that in yellow demonstration. So that's the left ventricle with the aorta coming out of it. The RVOT, we can see here, as again, from the 4 chambers view, we're acquainted with the regions. You can see here that the right ventricle, we have the pulmonary artery coming out of it with a bifurcation to right and left, and that would give the appearance of a Y here that you can see clearly, inverted Y. In this view, I would like to show you quickly, if you see the large one, here we will bring the LVOT, that's the LVOT, and the RVOT. I will regain again. That's the RVOT and the LVOT. So as you've seen, it happens in fractions of seconds. Just 3 seconds, you can see the LVOT and the RVOT. So you should be aware of what you're looking for. You should be acquainted with that the right side coming from the right, bifurcation, and the left side like the ballerina foot. So all can occur in seconds, and you can get back to it to demonstrate the LVOT clearly and the RVOT clearly. The 3 vessels view, we talk about the pulmonary artery, aorta, and superior vena cava. And they should be going in manner PAS. The pulmonary artery is the largest, aorta is the mid, and the superior vena cava is the least. So that's very, very, very important, because we will see later on in pulmonary stenosis or aortic stenosis the difference in caliber between them. Ductus arteriosus, that's the V characteristic, V appearance, and we must demonstrate it, as you can see here, the first image, the standstill, and the appearance of a V image. That's very critical to demonstrate in a fetal echo scan. Additional views, the aortic arch in a sagittal view like a candy stick, and you can see the branching coming out of it. The ductus venosus, ductal arch, you can see here, it's like the hockey stick with no branching like the aortic arch. Common congenital heart diseases like the ASD, that's very common, ostium secundum, and it's in the mid region of the septum, and usually it closes. Ostium primum, it can occur caudally or downwards near the ventricles. VSD, the most important thing is to allow the color Doppler to demonstrate. You can see here the VSD clearly and a defect in the septum, while some cases we have something that's called pseudo VSD due to improper positioning of the probe. So you might be biased. The only clue that confirms the VSD is the Doppler having the characteristic H or the aliasing between both ventricles. AVSD, as you can see here, we have a central defect between both atria and ventricles. Overriding aorta, it means that the aorta is not exiting from the left side, it's exiting imposed over a VSD. So you need to be acquainted that we have a VSD, then the aorta coming out from both ventricles on top of that VSD, giving the Y appearance. Like that image. Double outlet right ventricle, you can see here that the pulmonary artery and the aorta are exiting from the right ventricle, giving this characteristic appearance. Aortic stenosis, I've mentioned, you can see here the LVOT, and there is stenosis in the caliber, the ballerina's foot. You can see that there is stenosis in the caliber of the aorta and aliasing of the Doppler. Coarctation of the aorta means that when we see the sagittal view, you can see here on the upper right plane that we have narrowing in the caliber of the aorta, and indirectly you can see the coarctation by hypertrophy of the right ventricle or hypertrophy of the left ventricle, or indirect dilatation of the right ventricle due to volume overload or pressure on the pulmonary artery. So if you can't see the coarctation or not certain, definitely you can pinpoint that the right ventricle here is dilated, or you can see that the left ventricle is hypertrophied. So you must recheck again in the sagittal plane to check for coarctation of the aorta. Pulmonary artery stenosis, you can see here, as I've mentioned, the PAS. You can see the pulmonary artery, the one on the top, you can see that the lumen is attenuated compared to the aorta below it. And I've just mentioned that the pulmonary should be the largest one compared to the aorta and the superior vena cava. Dilated left ventricle, it's very clear that the left ventricle failing to contract and significantly dilated with pericardial effusion. Hypoplastic left heart, that's a lethal condition, and he cannot survive actually after repeated operations. You can see here that the aorta, the left atrium, the left ventricle, the heart here, the left ventricle is very small and the left atrium is very small, and he doesn't survive after operations. TGA, you can see here that the aorta and the LV, the pulmonary artery, they are going in parallel. They should be crossing over together, but in the sagittal plane, you can see them that they are crossing in parallel, and that's the main clue of TGA. Actually, in the sagittal plane, you can see here that the LVOT and the RVOT, the one on the left side is the LVOT. You can see it clearly, ballerina's foot directed towards the right side, and the RVOT with the bifurcation also directed toward the right side. So here we don't have crossing, confirming that we have TGA. So in clue, after I've mentioned all this stuff, the tetralogy of Fallot could be diagnosed at ease. If you have VSD, as I've mentioned, you need to look for overriding aorta with the significant Y appearance on the top right. And if you have, it's very clear from the four chambers view that we have hypertrophy in the right ventricle compared to the left one. And definitely on the left side, as I've mentioned, in the three vessels view, if you have stenosis in the pulmonary artery, it will be very clear if we have PAS, as I've just mentioned. So if you acquaint these four findings, we have tetralogy of Fallot. The pitfalls, the maternal habitus, obesity can compromise the image. If we have early gestation and we need to check the heart, that also can compromise the image. And the outflow tracts might be missed, so needs practice. So the take-home message is that it might be difficult and time-consuming to perform dedicated scan, but actually you need to do it following the indications that I've just mentioned. And if you acquaint the four chambers view, the outflow tract, and the three vessels view, it will be sufficient to diagnose 80 to 85% of the common cardiac anomalies. Thank you so much.
Thank you, Dr. Wael, for your really simplified fetal echo.